Lauren and I are discussing something we quite commonly see in clinic, which is trigger finger. Trigger finger is that classic kind of sensation where someone feels like their finger gets locked into the palm of their hand and they have to kind of pry it open. And so we commonly share patients who have this issue, so we just want to briefly discuss that. Discuss perhaps the 55-year-old lady that I recently sent to you.
Yeah.
So they presented to me first, of course, and I think we've got a nice video of that as well, where essentially the pulley, which is this kind of almost fulcrum which sits like just over the joint, gets very thickened and swollen. I identify that obviously on ultrasound. Clinically, both of us, quite easily can recognise this, and then Lauren does her magic.
So I'd often have a feel first, and it'd be sort of a similar sort of assessment. You'd have a feel of their finger, feel for any sort of lumps and thickenings that you can feel sort of going through the flexor tendon as well, as they're moving that finger. Obviously, you look for active triggering as well. Some people don't though, do they? Sometimes it'll just be like a little bit of a catching rather than a full locking, or they might wake up first thing in the morning with it locked, but then the rest of the day seems to be all right. I've also had a couple of people where they thought it was the back of their finger that was the problem actually, and they thought maybe it was the tendons across the back that were snapping, but actually it's on the opposite side. So, and the other way round as well, so just something that I always tend to sort of have a double check on as well. But obviously once you've got a scan, then you know for definite.
And that segues perfectly into it. So the key thing is what we're offering is obviously, if you see myself in the first instance, or vice versa, it doesn't matter, it's having access to a scan in clinic immediately, where we can give that clinical diagnosis alongside diagnostics immediately. And so it just tells us what's doing, and then just to add into what Lauren's saying, you can sometimes, some patients might also feel like it's a bit like lumpy, nodular, so you can get a little bit of a cyst, which is a bit of fluid, which is essentially coming from this pulley again, which again, we can either manage kind of through more conservative approaches, but sometimes you can think about an injection if that's the kind of scenario where you're at, which are pretty straightforward and again can be done in clinic by myself.
Yeah, and what I did was looked at splinting. So there's different ways of splinting as well. What we look to do is to immobilise one of the joints of the finger just to try and offload the tendon, not make it work quite so hard, so it's not running backwards and forwards and sort of rubbing more through the pulley system. So just immobilising the knuckle joint or the full finger. Sometimes at night I'll do that just to make sure it's not catching and locking at night time for a few weeks, just to sort of calm it down. And then after that we look at strengthening and the muscles that are probably underworking and overworking depending on the types of activity and sports that the person is partaking in.
And just in terms of why does this happen, I guess a lot of people will be interested in that, is, so if you imagine all the tendons which are responsible for kind of making a fist and kind of flexing your wrist start on the inner aspect of the elbow. And so as they from muscle they go into tendons around here, and so if you imagine if there wasn't nothing holding them down, if you made a fist, you'd almost just bowstring, it would be like little bowstrings all the way down. You have these things called pulleys. So as Lauren was saying, depending on what activity you're doing, you might be overworking it. But then the other thing to consider from a medical standpoint as well is anything metabolic. So some people, it's very common in individuals who have poorly controlled diabetes, but other things like thyroid dysfunction can also come into it. But if you kind of rule those things out, then it might be just biomechanical weaknesses.
Yeah.
Is that fair?
And how would you rule out there being a different reason for the...
We just get blood tests done.
Yeah.
You see the profile. If it's obvious there's a precipitating factor in terms of activity driven, then they're going to be, once the diagnosis is done for myself, then they're going to be sitting with you and basically working strengthening.
Yeah, absolutely. So I look at offloading the long flexors and always then working the small muscles, the intrinsic muscles of the hand, to get them as strong as possible, and they're normally the ones that are underworking while the flexors are overworking. And sometimes it is just a case of maybe just a sudden increase in load or amount of time spent in a certain activity that suddenly prompts this trigger finger, rather than it being necessarily about discrepancies between the muscle, the intrinsic versus extrinsic. Sometimes it is just that sudden increase in load, like a holiday or a trip for climbing, so 5 days a week, back to back, that sort of thing, rather than just sort of the couple of times a week they were doing before.
Yeah. And very occasionally we do sometimes need to do an injection, which is straightforward to do. It is a needle in the palm of your hand, so it can be a little bit sore, but it's nothing to be overly worried about. But that's a decision Lauren and I can make between us, based on how we're getting along with all the strengthening and all the immobilization, etc. And the idea in terms of statistics tell me, if you think otherwise, with one injection and physiotherapy, you can get rid of this in about 80-90% of cases. Yeah. But that is another thing we have in our armory, and so for the most part we can get this sorted out between us.
Yeah, absolutely.